Good afternoon, ladies and gentlemen. I'm very, very happy to be in your midst. As a matter of fact, I'm very excited at the opportunity to present myself and my solution to what I consider a potentially global problem to this audience. When we took some pictures a few days ago, and Levy told me, "Oh, you look sophisticated." I said to myself, in Africa, we don't talk of sophistication. We talk of the basics. We are hungry, we are dying because of lack of solutions to the problems, what we call day-to-day problems. I'm Dr. Ovadje. I'm a medical doctor by profession, and I practice in the developing world. I was trained in Nigeria, a developing country, and I've practiced medicine all my life in a developing country in Nigeria, and I have great insight into the developmental processes, problems of this part of the world, particularly in my area of rehabilitation, healthcare delivery. Again, like I said, I've been a standalone for quite some time. I'm a standalone in my class presently. I was also a standalone at the Tech Museum in 2002, the only African, and standalone in 1995 when the World Intellectual Property Organization declared me the best African scientist and the winner of the White Gold Medal. Standalone in the year 2000 when the World Health Organization declared me the first African winner of a Japanese award, the Sasakawa Gold Award. I'm happy to talk to you about my partner, who is a conflict trade engineer, production engineer. He's was a visiting professor in Stratfield and in Glasgow. He was a pioneer chief executive officer of one of the top government agencies in Nigeria. But then what is interesting about his character is that many of you who know about Nigeria would know that one thing that is a recurring decimal is the question of corruption. This is one chief executive officer that left government service, retired, without stealing government pots. Like I told you, that's a young lady with me on a trade mission to South Korea during our market investment drive. That's me at the other side with an international reporter. I want to talk to you about a problem that is common in my part of the world, the problem of lack of availability of blood in the developing world. Quite often, I'm routinely an anesthesiologist, and I work in the operating theater. But quite often, I'm called out of the operating theater to see victims of internal bleeding. In this case, I'm talking of women of childbearing age who suffer from the catastrophe of tubal rupture called ectopic pregnancy, and they bleed into the peritoneal cavity, and they are brought in a state of shock and imminent renal shutdown and potentially death. I am brought face to face with somebody who's crying for life, and there is no blood. The blood banks are not dependable. You cannot depend on them. If they have blood, the blood is not safe. The blood is expensive. But these patients have the solution. The solution is right in the body of this woman who is going to die if I do nothing. Because the blood that she needs to be alive is there. It's locked up in the body cavity. The problem is, how do I get this blood out of this cavity and take it back to the circulatory volume and restore her blood pressure and then save her life? But I have the solution. I was excited. I'm excited at the thought that I have the solution. And this solution is easy, is simple, is adaptable, and is capable of providing quality blood. I have here before you a piece of plastic contraction. Very simple. It's made up of three components, two proximal parts, the body, what we call hospital clay body, and attached to a manually operated pump. It's made up of, it's also adaptable to a system of tubes, plastic tubes. In medical parlance, we call them catheters. One of the proximal tubes is attached to the manual pump, and this tube is attached to a perforated nozzle, plastic nozzle, that goes into the body cavity. A gentle pressure on the pump creates a vacuum within this system, and then draws the blood from that body cavity through this system, purify it, send it to a reservoir bag. I'd like to tell you about what is currently done in developing countries. This is a pathetic solution to a difficult problem. Doctors in developing countries in a bid to save somebody who is dying go to all extents and open up the patient and thrust the bowl into the abdominal cavity to scoop the blood and pour it through layers of cloth called gas. And they filter it into open bowls. I wonder what it will look like if you wake up in the middle of an operation to find somebody with a bowl in your abdomen. You might kick the surgeon. I'm an anesthesiologist and I put people to sleep so that they don't see all that the doctors do to them. But I thought this should not be permitted. This should not be allowed to go on too long. So I designed this system. This is the system, simple contraction. The blood is being taken from this patient as we are operating. And then the same blood goes into the reservoir bag. When the collection is over, you can lift the reservoir bag above the patient and give the blood by gravity. This same solution has been extended to victims of violence and road traffic accidents. I was giving lectures to a group of resident doctors, and I was called out to see this young boy from the college. He had been stabbed as a result of student violence and was restless. He had what we call tachycardia and tachypnea. That is, he was breathing fast. He had difficulty in breathing. All I did was to get this piece of equipment, thrust it into the mid-axillary line, and, of course, the blood was drained out, and the young man became restful. The device, I tell you, is very simple, as you can see. And the components are available and inexpensive. I have a pump that cost me $5, and all the components units that I described earlier, all put together cost less than $5. And of course, because of lack of infrastructure in my part of the world, I needed to go outside to develop this technology. In Italy, it was too expensive for me. The 200 units that we used in our clinical trials were done by a Becker company in Italy. That was too expensive for us. And so we identified a low market, a low technology market, and we went to India. And by the time we finished with the manufacturing, the bill of material of our sampled products came to $15.55. Our customers are doctors, surgeons, anesthesiologists who are the clinical transfusionists, obstetricians and gynecologists. These are doctors, experts in the field. They are already used to this technique of going into the abdominal cavity and salvaging blood that is locked in there and give it back to the patient. We are not teaching them a new technology. We are not teaching them a new technique. We are just introducing or providing them a tool that allows them to implement the familiar scooping technique which they are familiar with. So the solution is adoptable. I get excited when I wake up in the morning and I find requests in the newspapers. This was from the internet. of doctors from the West African sub-region calling me to introduce my solution to their region. I printed it out here, while I was here, of doctors in Ghana, making demand of me and asking me and urging me to introduce my settling technique in Ghana. We've got a couple of testimonies. They bear testimony to our competence to perform and the competence of this technique of blood recycling. A Swiss study in 1996 was conducted using our technology against a European device called the Socotrans. The two devices were studied and the Swiss report came, and I quote, "Overall, we were rather surprised by the efficacy of the device in relation with its simplicity of use. Our analysis proved a real efficacy of the system that could find a vital clinical application in critical situations." This was the report of Professor Morgan, the Chief of Medicine, General University Hospital. This study was conducted under WHO execution. That was the highest level of censorship in the medical world.